Good evening, and welcome to tonight's Men's Health webinar with Dr. Itai Goldenberg. Tonight, we have the pleasure of hearing Dr. Goldenberg talk about signs, symptoms, and treatment options for erectile dysfunction and stress urinary incontinence. Dr. Goldenberg will start with the incontinence portion of the presentation and then move on to erectile dysfunction before introducing a patient who will talk you through his journey in treating ED. And then we'll open it up for questions and answers from Dr. Goldenberg and the patient. I invite you to ask questions anytime during the presentation. Simply navigate to the chat function, type in your question, submit it, and Dr. Goldenberg will answer it at the conclusion of the webinar. Dr. Goldenberg, the floor is yours.
Mike, thanks for the introduction. Thank you all for coming and taking time out of your day to listen to this presentation. I hope it's helpful. My goal today is to speak on men's health on two issues like Mike mentioned. We're going to talk about stress urinary incontinence and then talk about erectile dysfunction. I think you covered this already. This is me. My name is Itai Goldenberg. I'm one of the urologists at Urology of St. Louis. We have a group of 26 urologists. We surround the whole kind of St. Louis metro area, including offices in St. Louis, in West County, and in Illinois. I practice in our office over by Missouri Baptist in Town and Country at the Walker Medical Building. I also see patients twice a week at Anderson Hospital in Illinois. I did my residency training at WashU, where I learned urology. And then after I finished my urology training, I did an extra year in New York City, where I did a fellowship where we focused on men's health treatments, focusing on male sexual health, incontinence, as well as fertility treatments. So I want to talk about a couple things. We're going to start talking about male stress incontinence and what the options for treatment are. Before I talk about anything, I want to say kind of what it is and who has it and what are the causes. So if you think about what happens when a man urinates, the kidneys, really aren't pictured here on the screen. They make urine. Urine then comes through a tube called the ureter into the bladder. The bladder is a muscular structure that that's very stretchy. When it's empty, it's all the way empty, and as it fills with urine, it stretches almost like a water balloon. But it's surrounded by muscle. And so when the bladder squeezes, the bladder then pushes urine through this tube called the urethra. The urethra is where the urine passes through. When you urinate, stopping you from urinating at all times and blocking the urine when you don't want to pee are two areas of protection. One's inside the prostate, and another is this area here called the sphincter. The sphincter is a muscle that sits contracted or closed at all time. When a man doesn't want to urinate and to hold the urine, that muscle is tightened involuntarily. And when it's time to urinate, that muscle relaxes and lets the urine flow. So when someone has incontinence, which is the involuntary loss of urine, there's really two major reasons. One is stress incontinence. Stress incontinence is when you cough, sneeze, lift something heavy. If you increase your abdominal pressure, it causes a stress or pressure on the bladder. The bladder is then pushed on, and the urine can then leak through the urethra if those muscles, those protections in the prostate and in that sphincter aren't sufficient to keep the urine inside. The other type of leakage is called urge incontinence. Now, urge incontinence is when the bladder causes that stress. The bladder either squeezes too much or doesn't stretch as much as it should and causes pressure on its own, pushing the urine through. This is often men that have this feeling of I got to go and I got to go right away and then have some leakage. Some men and women do have potential of having mixed incontinence, which is a combination of both of these types of leakage. So focusing on stress urinary incontinence is what we're going to talk about primarily today. Stress incontinence, again, is the type when you cough and sneeze and lift something heavy that you have leakage. This type of leakage is really associated with men that had some type of surgery in the pelvic area. Most commonly prostate cancer surgery, but often non-cancerous prostate surgeries or bladder surgeries. But men that have prostate cancer surgery, most commonly is the radical prostatectomy when the prostate is removed for prostate cancer. Approximately 10% of those guys do have persistent leakage after a year from surgery. Almost all men have leakage initially after surgery. It usually clears up for many men over the course of that first year. But then subsequently, about 1 out of 10 men have sufficient leakage that is bothersome to them to necessitate treatment. And why does that happen? So when a man has prostate cancer, if you see here, the bladder sits here. This shows the bladder and the urethra coming out this way as opposed to downward like on the previous picture. The prostate sits here. When the prostate's removed, what's called a radical prostatectomy is performed, where an incision is made above and below the prostate, and the prostate is removed. The nerves that run here next to the prostate are spared and pulled away. Those nerves are really important for erections, and we'll talk about those later. And then what happens is this gap is then closed and brings the urethra up to the bladder. The muscle that's left behind is that sphincter muscle that's still there. But you have half of the muscle that was protecting you before that was in the prostate that's no longer there. So now all of your continence or control from leakage is only in this muscle that's left behind. So what are some of the options for treatment for stress urinary incontinence? So in the short term, we often talk about behavior modifications. So reducing how much fluid you drink, planning to go to the restroom, what we call timed voiding, making sure that you empty your bladder before you do physical activity that often promotes leakage. There's something called pelvic floor physical therapy and Kegel exercises. Any of the women that are on here would know that Kegel exercises are really commonly done when women have stress incontinence after childbirth. They do Kegel exercises, which are pelvic floor strengthening exercises. So we recommend that all men do those exercises after they have their prostate removed. And sometimes they'll need the help from a physical therapist to help strengthen those muscles or really help you isolate them. Additional things like pads, diapers, condom catheters, catheters inside or outside, or clamps on the penis are ways to prevent leakage. Pads are usually the way that we measure how much leakage a man has, either it being diapers or pads that are more of a liner. And these do have a significant cost, and I try to keep this in mind when I talk to my patients about, even if we don't move on to some of the surgical procedures that I'll talk about soon, there is a real cost to using pads, especially if you're using 5 pads a day or something similar. But after the short term, so after the first year, after the prostate is removed or whatever treatment was done that started the leakage, if you still have bothersome leakage, there really are 2 surgical options that I really want to focus on today that are options for men. One is called a male sling. A male sling is a support for the urethra. It's an extra backboard helping that muscle that you already have, giving it some extra strength and extra support so that when you do cough or sneeze or lift something heavy, there's not significant leakage. And the other is an artificial urinary sphincter. This is a device that's placed around the urethra to replicate the function of the natural sphincter that was there. This is really best for men that have heavy leakage or that have failed other therapies. It can treat all levels of stress incontinence. And I'll talk about these more here. So the advanced sling or a male sling is a piece of mesh. That mesh is placed on this, you see on the screen here, this blue represents the sphincter mechanism that was left behind after the prostate was removed. What happens is this mesh is placed on the tissue right next to that area and then tightened up and looped through your pelvic bones. It's anchored in place in that way because it's through your natural bones, and then gives extra support. And you can see on the subsequent picture that blue area is much larger. The support that you can get from your natural sphincter is much bigger and is very helpful. That said, you have to have a sphincter that still works in order to have success with the surgery. It really is ideal for patients that have 4 pads or less per day of leakage. I usually ask men that they have some residual control, even if they don't have complete control of their urine, but they're able to control to some degree. That tells me that their muscle is still working. It works best for men that had their prostate removed that did not have radiation as well. There's a very high satisfaction rate. Well over 90% of patients are happy they had it done or would recommend a sling procedure to their friend. What's nice about the device is it's a piece of mesh that's placed inside, but once it's in and you've healed from the surgery, you don't have to interact with it. It's in there and always provides protection. The other option is an artificial urinary sphincter. So an artificial sphincter, or AUS, is a 3-component device. It's a cuff that goes around the entire urethra, really replacing the sphincter that you used to have. There is a control pump that sits in the scrotum, in the skin next to the testicles, and then this balloon here that's placed in the pelvic area, and this is a pressure balloon. What it does is it's always putting pressure on this cuff, allowing the urine to stay in until you press the button on the control pump to let the urine flow. The cuff is tailored to fit perfectly for your urethra. It's made through two small incisions, one under the scrotum and one lower on the belly to put the device inside. This is the gold standard to really replace the sphincter that was damaged. I think it's ideal for men that had prostate cancer and radiation, men that had a sling and it didn't have sufficient improvement, or men with severe incontinence, usually more than 4 pads a day, or that if we did a cystoscopy or we looked in the office, you really didn't have any muscle left behind to allow for a sling. I hope this video loads here. Let's see. Okay. So this shows how the artificial urinary sphincter works. This is the control button that lives in the scrotum. You press this every time you want to urinate. What happens is then the cuff opens, allowing the urine to flow. Then over the course of 1 to 3 minutes afterwards, the cuff then refills and then blocking the outflow of urine until you're ready to urinate again. Very high satisfaction rate with this procedure as well. Well over 90% of patients are happy they had it done. It's best, like I mentioned, for men with weakened sphincter. The whole device is concealed inside the body and has a high satisfaction rate. Any surgery does have risk. The male sling, if we put it inside, there's a possibility that it doesn't give sufficient improvement. It's a possibility we put the sling in so tight that you have difficulty urinating afterwards. There is a risk of irritation or pain from having mesh placed with the sling. With an artificial urinary sphincter, this is a device that's dynamic. It's always moving and changing. So there is a chance that that device can fail. The average device does last about 10 years, then oftentimes needs to be exchanged. There is a risk of injury to the urethra or erosion over time. Also, with an artificial sphincter in, it makes it more difficult to have other urologic procedures like catheters placed or scopes. And sometimes the device can be injured or need to be removed to have some of those procedures. Insurance normally covers either of these surgeries. To make sure that we have coverage, we will do a benefits investigation, making sure that you have coverage for the surgery. But for the most part, insurance often covers these as they are really a side effect of the cancer treatment. So I think to conclude with this part about stress incontinence, it's important to speak to your urologist, really keep a journal of how much you leak. Start by talking to the urologist you see for your prostate cancer, if that's what the reason that you have leakages. But I think important, if you're interested, to see someone like me or that's interested and does a lot of these incontinence surgeries to talk about what these options are and to see if you're a candidate for one of these surgical procedures with a sling or an artificial sphincter. Okay, so I think I'm just going to move on to talking about erectile dysfunction. Mike, do you want me to answer questions first?
I think we just moved to the ED portion, if you're all right with that.
Move to the ED portion and answer questions at the end?
Yeah.
Okay, there we go. Okay. All right, so changing gears slightly, I want to talk about erectile dysfunction and what are the treatment options. So erectile dysfunction, what is it, who has it, and what can cause it? To start out, to define things, erectile dysfunction is the inability of a man to achieve or maintain an erection that's firm enough to have sexual activity. It's very, very common, and it's really 1 in 5 Americans over the age of 20, and over half of men that are 40 or older. So very common, and affects approximately 40 million American men. To break down what an erection is, I think as a urologist, I think of it differently than just what an erection is. And so what causes you to have an erection? And the thought is that, first of all, you have to be in the right situation. Usually stress, anxiety, things like that can affect, the starting of the process of a desire to have an erection. The other part is you have to have the right amount of testosterone that can allow you to have that libido and sex drive to have the desire for the erection. Once that signal starts in your brain and goes down to your penis, you have to have normal blood flow into your penis and normal nerve endings in the penis that can react to that desire. If you look here on the screen, when at the flaccid state without an erection, your penis is made of 3 tubes. There's the 2 erectile bodies, 1 and 2 on top, and they're side by side. And underneath is the urethra we talked about before we urinate through. The 2 cylinders on top, these erectile bodies, then fill with blood. An artery brings blood inside, and the veins collapse in order to keep the blood inside. That function all has to work together in order to allow for you to have a natural erection. That process, like I mentioned, is important. It's important to have nerves that function nicely. So things that can affect nerve endings, like diabetes or medications, often affect that. And most importantly, it's a vascular thing. It's a blood flow issue. So men that have vascular issues, medications for high blood pressure, or any type of prostate cancer surgery or diabetes or heart disease can affect their ability to have erectile dysfunction. So how do these things affect? So diabetes is what I'll talk about a little bit first. Diabetes is a very common issue with men. 15 million American men have diabetes. And in men with diabetes, erectile dysfunction often comes in earlier than men without diabetes. It's probably because that diabetes affects not only the nerve endings with neuropathy, can also affect the blood vessels throughout the body and in the penis, causing there to be issues with blood flow. And for that reason, therefore, erectile dysfunction in men with diabetes often doesn't respond as well to pills as the general population. Men with diabetes can do their best to control and preserve their erectile function by controlling their diabetes, getting good glycemic control, following up closely with your cardiologist or your endocrinologist as necessary to really optimize your diabetes and reduce other complications, including erectile function. Erectile dysfunction and heart disease. Like I mentioned, to get an erection is a vascular process. It's blood flowing into the penis. And if you look, the penile artery, where you have 2, 1 on each side in each of those corporal bodies, is about 1 to 2 millimeters inside. It's a very small artery, and so therefore very prone to having an obstruction or blockage. If you compare that to the coronary artery disease, which is about 3 to 4 millimeters in size, much bigger, or the carotid artery, which is, if it gets occluded, what can cause a stroke. I focus on this because if you're a man that had a heart attack or has a stent placed or had a cabbage surgery, you know that you had blockage of an artery that was this size, 3 to 4 millimeters. And therefore, it's almost uniformly that any man that has significant narrowing of the cardiac vessels most likely does have narrowing of the arteries in the penis. How do you reduce your risk of erectile dysfunction associated with heart disease? Exercising, eating well, not smoking, reducing stress. Things that are healthy for your heart and help blood flow to your heart will also help your erectile function. Low testosterone, like I mentioned at the beginning, testosterone is the hormone that it's produced by the testicles and helps give man libido and desire. It's really common in the same age group that men start having erectile dysfunction, also have a drop of their testosterone. It's associated with a lot of things that are also associated with erectile dysfunction, like being overweight, having diabetes, having high cholesterol, and having high blood pressure. Excuse me. Men that have low testosterone also often feel tired. They have decreased muscle strength. They have a hard time losing weight. They can feel less motivated. They can feel sad. But sexually, often will have a decreased sex drive or decreased libido and have erectile dysfunction. There are lots of ways that we can treat low testosterone. To start off, we want to make sure that you actually do have low testosterone. So testosterone is checked through a blood test. You have to have 2 blood tests that show that your testosterone is low. That's less than 300 nanograms per deciliter. Testosterone is most accurate if it's drawn in the morning before 10 a.m. So I have my patients get 2 blood tests, and if they have 2 blood tests in the morning that both show their testosterone is low, those men are usually a candidate for testosterone replacement therapy. Those include pills, pellets, injections, and gels. And there's really pros and cons to a lot of those options, which kind of can be individualized, for the patient's need. There is literature to say that men that have erectile dysfunction and are given pills have a better response to those pills if their testosterone is also correct. Erectile dysfunction and prostate cancer. So this is a similar slide to what I showed before about incontinence. When the prostate's removed, as I mentioned, we make an incision here at the bladder neck, an incision here at the end of the prostate, and the prostate's removed. These nerves that run adjacent to the prostate or next to the prostate are peeled away in this neurovascular bundle. That can cause an injury to those nerves, and those are the nerves that continue down to the penis and allow for erections. Men often will have erectile dysfunction immediately after surgery that will return with time, but often about 50% of men won't regain the erections they had originally. That is men that are a year after their surgery won't have the same erections they had before. If you include into that also some men that have their prostate removed also have radiation therapy, or separately, some men choose to have radiation as opposed to surgery, those men also have about a 50% chance of having worsening of their erections. Erectile dysfunction and Peyronie's disease. So Peyronie's disease is often confused with erectile dysfunction. This is a different process. Peyronie's disease is scar formation in the penis that forms a plaque. So when a man has an injury to their penis, oftentimes it's an incidental injury, something they don't even remember happening. They can develop overhealing and scar or plaque formation in the penis. Most commonly, it's upward as demonstrated here in this picture, but sometimes it's right or left or downward curvature. And what happens is these erectile bodies, that you see here, which are what fill with blood when you get an erection, aren't able to stretch so much at the area where the plaque is. And therefore, you develop curvature in the direction of where this plaque is. This can cause difficulty with penetration. It can cause stress for the patient and for their partner. There are lots of options for treatment of curvature, either together or separately with erectile dysfunction treatments. Approved by the FDA in 2013, so already 9 years ago, is Xiaflex. Xiaflex is an injection into the plaque that can help break down that plaque. This is 8 injections in the office that can be used to reduce curvature. This does not treat erectile function, but would help with penile curvature due to Peyronie's disease. Surgical treatments can be done to help with penile curvature, including a plication procedure, which are sutures placed on the opposite side of where the curvature is, incision or excision and grafting, or a penile implant. The penile implant is a surgical procedure that would treat both erectile dysfunction and Peyronie's disease by replacing the inner parts of the penis with cylinders that can then be inflated. And I'll talk about that more in a moment. So what are the treatment options for someone with erectile dysfunction? So many primary care doctors and family practitioners will often be comfortable at this point to talk to their patients about erectile function. I think most primary care physicians are really comfortable prescribing pills and talking about the other risk factors, like I mentioned before, for erectile function. So oftentimes it starts by talking to your primary care and saying, I have erectile dysfunction, and what are some of my options, and what are some things we can start. But if you don't respond to initial therapy, or if you feel more comfortable doing so, it makes sense to see a urologist. A general urologist can talk about a lot of options, and then there's prosthetic urologists, people like me and some other people in the community who are specialized and really highly interested in treatment of sexual function that can really give all of the options. And so what are the options that are available? And I'll talk about these more in detail, but we'll talk about pills, we'll talk about wave therapy, injection therapy, urethral suppositories, a vacuum erection device, and penile implant surgeries. So oral therapy or pills have been on the market now for almost 30 years, I would say, maybe longer. These are PDE5 inhibitors. The most commonly prescribed ones are Viagra and Levitra and Cialis. These also have generic options now, which are much cheaper. They used to be more cost prohibitive, and now as they're generic are much easier to obtain. These medications work by allowing those blood vessels in the penis to be more excitable with excitement. So if take a pill like this, you don't get an erection. But if you take a pill like this, what happens is when blood flows into the penis, it stays in the penis longer and you get a stronger erection than you would have without that medication in your system. Viagra usually works really quickly. Cialis stays in your system longer. And some men do respond better to one or the other. It's important to note that certain medications, especially Viagra, are very sensitive to food, so they're best taken on an empty stomach. About 60 to 80% of men have some response to these pills, and in most men, this is the primary or initial treatment that we will give. There are side effects with these medicines. Most commonly are headaches, stuffy nose, and flushing. Some men do experience vision changes when they take PDE5 inhibitors. There are some medications that they cannot interact with. So men that take any type of nitroglycerin or nitrates for their heart health should not take these medicines because they can cause an unsafe drop in your blood pressure. So if you're on other medicines, it's important to let the doctor that's prescribing erectile dysfunction medicines know what all your whole medicine list is, so they can know if it's safe for you to be prescribed this medication. So I'm going to talk next about wave therapy. Wave therapy is a relatively newer option. Wave therapy is it's what's called low intensity shock wave therapy. The thought is that these waves are pushed through the penis into the corporal bodies and over multiple sessions. What we offer in our office are 6 sessions, each taking about 20 to 30 minutes that allow the blood vessels to be irritated by this wave and hopefully repair themselves and form newer, stronger blood vessels in the penis. What's the risk of this therapy? Well, number one, it hasn't been studied that much. It is an off-label use of a already approved device that's been shown to be safe for non-urologic conditions. And we found subsequently that it does help men with erectile dysfunction. It's really best for guys with mild to moderate erectile dysfunction. Because of the way it works, it irritates these blood vessels that are already in the penis and helps them get stronger. So we found that it really works best for guys who have issues with erectile dysfunction because of poor blood flow. So men that have their prostate removed, and that's usually injury to nerves, men with severe diabetes don't have as good of a response to the shockwave therapy than men that have purely issues with blood flow or vascular disease. What's nice about the therapy is it is very low risk. We find very little side effects of the therapy. I think the biggest risk is that you're spending time and money on a non-FDA approved therapy, which does not help everybody. In my experience, most of my patients get a mild to moderate improvement of their erectile dysfunction. Vacuum erection device. So men that haven't had success or haven't had success or don't want to try the other options can order a vacuum erection device. A vacuum erection device is a cylinder that goes over the penis and pulls blood inside. What happens is you have this cylinder that goes over the penis and the blood is then mechanically pulled in. Once it's pulled in, this ring is placed on the base of the penis in order to maintain the erection, and you leave that ring on until you're done with sexual activity. The upside of this device is that It works for most men. Almost 80% of men have success with it. However, there are a fair amount of side effects, including discomfort from the ring, bruising, or bleeding from the area where that ring is at, or the lack of spontaneity from having to use a device like this. A urethral suppository is another option. This is the medication that is placed in the urethra or in the natural opening, and a small pellet is pushed into the urethra and then dissolves. Then your body absorbs that medication and takes about 10 to 15 minutes really to kick in. About 40 to 50% of guys get improvement with it, but most of my patients say it's uncomfortable to place that device into the urethra and really don't love it. However, I do have some patients that say it's a very easy way to do, and it doesn't involve any needles. It's a small applicator that's placed inside. I do have a much stronger buy-in for my patients that are interested in injection therapy. Injection therapy is actually the same medication, that active ingredient that's placed in that urethral suppository, but instead of going through the urethra, is injected into the side of the penis. If you look here, like I mentioned before, the corporal bodies or the cylinders that fill with blood are these two top parts of the penis. This is the urethra down here. The needle goes in and injects into one of these corporal bodies. These two bodies do connect and talk to each other, so you only have to do one injection and both of those bodies will fill. 60 to 70% of patients have a good response to these injections and continue therapy. There is some men that stop using the medication either because they don't like using needles, they have pain or discomfort with the shots, or with time that they lose their efficacy. The biggest risk of those injections is you can develop Peyronie's disease or scar tissue, but the thing that I worry about is because that medicine is so potent, there is a risk of getting a prolonged erection. Therefore, if you're interested in injection therapy, we usually do a test dose in the office to make sure you understand how to inject it, make sure we're giving you a safe prescription dosage so that when you go home, you don't have a problem. And then the other option is a penile implant. A penile implant is a permanent change to the body where what we do is we place cylinders into and replace these two cylinders that you have are demonstrated here in the penis. Those cylinders are controlled by a pump that sits here inside the scrotum. When you want an erection, you squeeze this pump and you shift fluid from a reservoir of fluid into those cylinders, allowing for an erection. Very highly satisfactory. Well over 90% of guys are happy they have a surgery like this done. There are risks like any surgery, including infection or bleeding or injury to surrounding structures. The average device lasts around 15 years or so, so there's a chance you may need repeat surgery down the road. There are different types of penile implants. The most common implant we put in is over here on the right. This is the 3-piece device with a pump that sits in the scrotum, similar to the artificial urinary sphincter pump that we showed originally. The 2 cylinders that replace the inner parts of the penis and a reservoir here in the pelvic area. There are some more simple devices, either a 2-piece device that only has the cylinders and a pump. This one does not really completely deflate like the other one. And a concealable spectra device, which is a malleable device. This is a device that is always firm, that you can just bend up and bend down. It's much easier to use, but keeps a man with an erection at all times. Part of the reason that the 3-piece device is the most common device place is that this is the only device that comes pre-coated with antibiotics. This is a special antibiotic that is on the device. That's why it has this yellow color to it, and that's slowly released after it's implanted in the body to reduce the risk of infection. The risk of infection with a device like that is about 1 to 2%. So how does it work? Let's see here. Should load here. Okay, so if you look in this diagram, there's these 2 cylinders here that are inside the penis. The pump sits here inside the scrotum. As you squeeze that pump, you're shifting the fluid from the reservoir into the cylinders, allowing for an erection. The erection can then be maintained as long as you'd like. And then you press the release button. Once the button is pressed, the fluid then leaves. and then you often will squeeze the penis to get all the fluid out of the penis to allow complete evacuation. Here's a live patient demonstration. So if you see, so you'll see here in a moment, this will be a patient that has an implant placed, and he'll show how he will pump here. So you bring the pump up to the surface of the skin, usually holding it steady with one hand. You can see the outline of it right here. You then squeeze the pump. As you squeeze the pump, the fluid is then shifted into the cylinders. You can squeeze that pump as much as you want. You cannot over pump the device because there's only so much fluid in the reservoir. The two cylinders are then full, giving a natural appearing erection. And then when you no longer want to have an erection, you bring the pump up to the skin. You can find right there the release button. You press the button. That opens the valve, allowing the fluid to then leave the penis and then go back to the reservoir. And you'll see here in a moment, the patient will squeeze the penis in order to get all the fluid out of the penis. And at rest, it's very concealed. Very highly satisfactory surgery. Well over 95% of patients are happy that they had it done and would recommend a surgery like this to their friend. As I mentioned, there are significant risks when we do a surgery like this. The 1 to 2% of risk of infection is what we worry about the most. That's why I give antibiotics to my patients before, during, and after the operation. I tend to, if I can, place a device that's coated in antibiotics. After the procedure, most people do have pain. That's normal. That pain usually lasts significantly for about a week or so, but I do have some patients that have prolonged pain for more than 2 to 3 weeks. There's a possibility the device doesn't work as you hoped it would, or that you're disappointed with the end result. That said, most patients, well over 90 to 95% of guys, are happy they had it done and are happy with their response. It's designed to be a permanent solution for erectile function. It's spontaneous and concealed inside the body. Many implants have been done. Over 500,000 have been performed by Boston Scientific, and it's been around for over 40 years. Insurance oftentimes will cover the placement of a penile implant. That's not uniformly, and we will make sure that we have crossed our T's and dotted our I's and make sure we know what any out-of-pocket cost would be for you before we do your surgery. Overall, treatment of erectile dysfunction, there's not one answer for every patient and every couple. There's lots of options like I outlined. I tried to discuss most of the common things that are performed for ED, but there definitely are more out there. The idea is that there's lots of things that can be done, and there's options that we can tailor for you and for your partner. I think the first step is coming to a webinar like this, or in talking to your primary care doctor, talking to your partner. And then if you decide that you'd like to move forward, talking to a urologist or talking to a prosthetic urologist that can offer any of these options. Here's some safety data. And then I think the next step is I'm very lucky to have Cliff here to talk about his experience. And then I think we'll open the floor to questions and kind of go through them.
Good evening, everyone. What you're going to hear basically is the story from the time I was diagnosed with prostate cancer, going through everything the doc just talked about, and finally ending up with ED and then curing the ED. When I was 58 years old, I was diagnosed with prostate cancer. And I decided at that point, even though the doctor said it was a very slow growing cancer, I wanted it removed because I didn't want it going anywhere else in my body. So I had my prostate removed. And as a consequence of it, as Dr. Goldenberg said, I ended up with ED. So I went back to my regular physician and he did put me on Viagra. And I got no response on Viagra, even though I used it correctly. So they put me on Cialis and Levitra, went through all the different dosages. And what happened to me basically was I got terrible, terrible headaches and got to the point where I just couldn't pick my head up off the pillow. So I had to finally give up the pill therapy. I then went back and spoke to a urologist, and he suggested the external vacuum device. I will say the vacuum device did work. Unfortunately, it is not spontaneous whatsoever. And two of the drawbacks of the vacuum device that we found, my wife and I found, is that number one, your penis becomes a little cold, and it also turns a little blue. And that is a very big turnoff to a lot of your partners. And the reason I say partners is ED is not just a male issue. It's an issue for both the person who has the ED and the partner. And it's to me, it was very easy to talk with my wife and discuss what my problem was. A lot of gentlemen that I've talked to I've spoken to said, you know, I have ED. My wife thinks I'm having an affair with somebody else. She thinks I don't love her anymore. And as you guys know, that's the farthest from the truth. So keeping your wife or your partner involved in the whole process is very important. Finally, after the erection device did not work, I went into a major depression because I didn't know what else to do. And for 2 years, I had nothing, no erections, no nothing. Luckily, I got an invitation to a meeting kind of like this, but before COVID hit, back in 1960. And I learned about the Muse, the little pills, and the injections, and the IPP, the inflatable penile prosthesis. My wife and I talked about it, and we decided that the inflatable penile prosthesis was the best for us. And a day after my 60th birthday, I ended up having the implant done. I am now 76 years old. I had my first implant last 14 years. It never gave me 1 day's problem. It always gave me an erect, flat, hard, rigid penis, good for any type of intercourse we wanted to do. After 14 years, it did decide to not work anymore, so I did go back to the doctor and had a replacement done. And I'm happy to say now, for 2 years, I've had the new one, and it works the same way. A lot of guys ask me things such as, well, you know, how soon can you go back to working out at the gym? Well, normally I would say when the doc tells you it's time you can have relations again with your wife, with your partner, you can go back working out at the gym. The only thing I suggest is you don't start out where you left off. You start out a little light and work your way up. Another thing they ask me is, well, when I go in the airport, when I go through the metal detector, will it go off? The answer is no. They ask me if it stops you from having any type of scans done, such as MRIs, PET scans, CTs. If you need a cystoscopy, it doesn't have any effect on any of those. I would say if I had to live my life over again, the implant will basically change your life. Without having erections, I think most men feel that they've lost their manhood. When you get the implant and you're able to have an erection anytime you want without having to take pills, without having to make sure that the medication is, you know, in a refrigerator when you travel, you find out that you bring back into your marriage a what's the word? You basically bring back you feel like you're 15 years old again, 18 years old again. It changes your life completely. And it's unfortunate that men do not talk with other men usually about this. Most of us don't even talk to our primary doctor about this. We go into the primary doctor with some other issue, and it just so happens to slip out. But actually talking to the prosthetic urologist is the best way to go. And all I can say is I have been very, very happy for the last 16 years with the prosthetic implant. And if I live another 16 years and it fails and I need another one, I'm calling Dr. Goldenberg and I'll be on the list to get another one done. It's as simple as that. So I'll turn it back over to